Back in 2024, when Dr. Ocean was a new cardiothoracic surgeon at AdventHealth Ocala, he started to talk to us, the nurses in CVICU, about something called a PAPi score. It wasn't something that we were using on a regular basis. And he taught us how to do the calculation and told us that this score could help us to recognize right heart failure in our patients long before any kind of invasive diagnostic tools could find this. Our manager learned about this and he encouraged us to find out more about it and if there was a way to get this entered into EPIC as an automatic calculation to help with clinical decisions and save us some math. So our study set out to answer an important question. Can using the PAPi score lead to earlier interventions and improved outcomes for our patients? I'm Anne-Marie Sassong, a critical care nurse at AdventHealth Ocala, and I'm very excited to lead you through what we have learned. Here's our project team. I've included our contact information in case there are any follow-up questions. I think one of the major motivators for this project was not having to do the math in our head. Dr. Ocean could do it so quickly, and we would have to come up with it right away on the spot sometimes. So our project goal was to provide evidence that including an automatic PAPi score in our EPIC charting would be a useful prognostic measure. The Pulmonary Artery Pulsatility Index is an emerging hemodynamic parameter that may predict adverse cardiovascular events, including right heart failure. This review examines whether PAPi predicts adverse cardiovascular events in post-cardiac surgery patients specifically. Though to do the project, we had to draw from diverse patient populations, and we evaluated how the PAPi correlates with heart failure, myocardial infarction, and mortality. We looked at populations receiving LVAD, receiving Impella, and just basic cardiac surgery patients as well. Here is our PICO question. In post-cardiac surgery adults, will using a PAPi score to evaluate the risk of complications result in a reduction of mortality as compared to patients who are evaluated using standard measures of risk? So our intervention is the PAPi score, and our outcome is the reduction in mortality, better patient outcomes. For our literature search, we used Ovid synthesis and searched for articles using keywords including PAPi, cardiac surgery, heart failure, mortality, and pulmonary artery pulsatility index. We found 19 relevant articles published between 2020 and 2024. This included one systematic review and meta-analysis, which provided level 1 evidence, along with 18 primary studies of various designs. The systematic review alone included data from over 20,000 patients, giving us a substantial evidence base to draw conclusions from. Here are 4 key studies from our literature review. The YIMS systematic review from 2023 is our highest level of evidence at level 1A. It analyzed over 20,000 LVAD patients across 16 different studies and found that lower PAPi was consistently associated with right heart failure and death following LVAD implantation. An important finding was that a single PAPi cutoff value could not be universally defined because the optimal thresholds depends on pulmonary vascular resistance of the patient. We'll talk more about that when we talk about the ZERN study. The wrong study from 2020 was a prospective observational study of 119 CABG patients. And this study found that the PAPi measured before the cardiopulmonary bypass, so they measured it before the patients actually had surgery, could accurately predict and potentially even diagnose post-bypass right ventricular dysfunction, so the right heart issues. The Tanaka study from 2024 looked at 259 patients undergoing transcatheter tricuspid valve interventions and found that the lower PAPi scores correlated with lower procedural success rates. Finally, the ZERN finding from 2022, which we're going to discuss in a later slide, followed 8,000 patients for 10 years and found some striking, provided some striking data, which we'll discuss in a little bit. This last study I wanted to include in this presentation due to the increased number of Impella implantations that we've been seeing in the CVICU. This slide is basically saying that the PAPi score showed significant correlations with multiple hemodynamic parameters in Impella patients. It talks about the cardiac index, the pulmonary capillary wedge pressure, the central venous pressure, the central venous oxygen saturation. Unlike any single measurement that only captures one aspect of right ventricular function, the PAPi correlates with multiple hemodynamic indicators at once. So when we calculate the PAPi, which is actually a simple calculation made from the diastolic and the systolic measures of the pulmonary artery pressure as well as the central venous pressure, you're getting a more comprehensive picture of the overall right heart status and tissue perfusion in the patient. It's better than just one tiny piece of the puzzle. So this is showing that the PAPi is a useful big picture metric for measuring or monitoring the right ventricular function during Impella support, specifically in this study in cardiogenic shock, because it reflects changes across multiple hemodynamic parameters. This slide shows some of our key findings from our literature review. Specifically from the Zern study, over on the right side of the slide, you can see in their cohort of over 8,000 patients comparing the lowest PAPi quartile to the highest PAPi quartile, they found a 60% increase in all-cause mortality, an 80% increase in major adverse cardiovascular events, and actually a 100% increase in heart failure hospitalizations. In that study, even the second and third quartiles had elevated events compared to the highest quartile. Some of the other findings on this slide, you can see that the lower PAPi values across all the literature we studied are consistently associated with increased risk of right heart failure and also mortality. In the LVAD patients in particular, the lower PAPi was associated with right heart failure and death following implantation. In the CABG patients, post-CABG patients in particular, the pre-cardiac bypass PAPi predicted the post-cardiac bypass right ventricular dysfunction. Most of these studies found that a single universal PAPi cutoff could not be defined and that the optimal values depended on pulmonary vascular resistance. But the Impella study in particular showed that the PAPi score was accurate even in the face of differing pulmonary vascular resistance values in the patients. Assessing the evidence, we found that we do have enough high-quality evidence to show the value of the PAPi score. The systematic review by Yim and colleagues alone provides strong level 1 evidence demonstrating the prognostic value of PAPi. We also have multiple level 3 prospective studies and level 4 retrospective studies that all point in the same direction. Did we answer our PICO question? Okay, so partially. Our literature search did not find direct evidence showing that using PAPi-guided care actually improves patient outcomes compared to standard care. However, the literature clearly demonstrates that the PAPi is useful for predicting patient complications after cardiac surgery, and that lower PAPi values correlate with increased adverse events. It also shows that the PAPi has a significant value as a risk stratification tool, particularly for right ventricular dysfunction. The limitation is that no studies have directly compared outcomes between PAPi-guided intervention versus the standard of care. Here's a summary of our practice recommendations. We recommend including the PAPi score as part of our hourly patient evaluation. We believe this might provide some valuable prognostic data. So we propose add the PAPi as an automatic epic calculation, include this in post-cardiac surgery monitoring, and of course we're going to integrate this with our PA catheter documentation. We expect the benefits of this would be early identification of at-risk patients, particularly for right ventricular dysfunction, data-driven clinical decision report, and improved risk stratification capability. And just for fun, I included the PAPi formula there, which is subtracting the diastolic pressure of the pulmonary artery from its systolic pressure and dividing it by the right atrial pressure. On our floor, we use the CVP, which is a good estimate of the right atrial pressure. Here are the references that we used for our literature search. These references span from 2020 to 2024 and include the systematic review by Yim and colleagues, the large cohort study by Zern and colleagues, and multiple other studies examining the PAPi use in various cardiac surgery and cardiac procedure populations, including the LVAD, CABG, valve intervention patients. All the citations with the full DOI links are available in the attached PDF. Thank you for attending our presentation. I hope that you enjoyed it.